So today we're having this conversation because we all know that young women with disabilities are more vulnerable to adverse sexual and reproductive health and right outcomes than their peers. And we know that they lack access to sexual reproductive health rights, services, and commodities. And we all know, or we can imagine, that the recent COVID epidemic and the accompanying necessary but very harsh countrywide lockdown has had a further impact on young people living with disabilities. And for those of us in South Africa, Sunday night's move to put us back on adjusted level 4, while we supported and while it was and is necessary, we assume that once again it places young women with disabilities at incredibly heightened risk. But despite knowing all of this, and I imagine every single person in this webinar goes, yes, we know this, we really know very little about the actual issues that are faced on a day-to-day basis and that continue to be faced with regards to sexual reproductive health and rights, access to services, exposure to violence and abuse by people living with disabilities. We don't really have a human face on what's happening. So that is why we're here today. This is our first webinar where we're going to start this conversation about what we call the forgotten agenda. And today we're going to talk about what do we know now and where are the gaps now. And we're going to be hearing from young people with disabilities, service providers, governments and NGOs, development partners, researchers. We're going to be hearing what we currently know. And then this is an ongoing process. We will come back again and have a webinar again on International Disability Day, which is the 3rd of December. We will be having further conversations with stakeholders. And then next year in March, we will come back and have our final webinar where we will share our research findings and our policy and programming recommendations. So this is a process, and we hope that you stay with us over the period. Finally, we're particularly excited to be doing this webinar today because today, the 30th of June in South Africa, is the last day of Youth Month, which is largely celebrating the massacre in Soweto in 1976 and is now being used to remind everybody not to forget about the youth. And we're saying let's in particular not forget about the youth living with disabilities. So we will be together for roughly 2 hours. It is long, however, we are using different mediums, so hopefully we will keep you with us for the whole time. We will have a brief introduction from the project leader, Johannes Hancock, and then a keynote address and a presentation. And then we will have a very powerful poem from a young woman, and then we will turn to a round table to hear from voices on the ground. In between, we will take questions from yourselves and give panelists a chance to answer. So let me begin then by handing over to Professor Johannes Hancock. So Jill works with us at the Gender and Health Research Unit at the Medical Research Council. In this last decade, she's focused primarily on sexual reproductive health and rights for vulnerable populations across Southern Africa, particularly including women, youth, adolescents, and people with disabilities. She's very well known for contributing to adding to our understandings of SRHR needs of people with disabilities. And she uses a wide range of research tools to do this. She uses ethnography, epidemiology, situation policy analysis techniques. She has developed and piloted a number of interventions and has had a huge impact on translating the research outcomes into policy change across the region. Jill, let me hand over to you to briefly introduce the project. Thank you.
Thank you very much, Samantha, and thank you everyone for joining us and giving us the opportunity to share our thoughts about the Forgotten Agenda project. In introducing this project, I would like to highlight a few facts to kick us off. Firstly, the group of people we are looking at today, young women with disabilities, are part of a widely marginalized group, namely people with disabilities. We know that people with disabilities make at least 15% of the world's population, and that they are part of all key populations that are targeted by sexual and reproductive health and rights programs, and are among those living with HIV. Hence, without people with disabilities, ending inequalities and providing access to sexual and reproductive health for services for all is impossible. However, people with disabilities experience many health disparities. The London School of Health and Tropical Medicine Missing Billion report shows us that people with disabilities are 2 times more likely to be infected with HIV. are 2 times more likely to be malnourished and die as a child, and are 50 times more likely to have catastrophic health expenditures than their peers without disabilities. Despite these vulnerabilities, many people with disabilities experience barriers to access services, as these are sometimes not physically accessible, so they don't have ramps or disability accessible toilets and doors. They may not provide alternative modes of communication, such as sign language or simplified information for people with intellectual disabilities, or Braille for those ones who are blind. Or they may have staff who hold negative attitudes or misconceptions about disability, or simply lack the skills to accommodate disability needs. Women with disabilities are even more vulnerable because they experience discrimination based on gender and disability. For instance, the What Works program to prevent violence against women and girls with in all their diversities shows that women with disabilities are twice as likely to experience intimate partner violence than their peers without disabilities, and that this risk increases with degree of disability. In addition, the census and the General Household Surveys in many countries show us that persons with disabilities are, and here in particular women with disabilities, are more likely to be poor and less likely to earn an income than their peers without disability, and that is closely associated to a lack of access to education. Young women with disability experience even more marginalization in terms of their sexual reproductive health and rights. They may not have access to menstruational hygiene products, information about STIs, contraceptives or condoms, or be simply seen as asexual and oversexed and easy victims of sexual violence. Nevertheless, their experience is often not spoken about, in particular in resource-poor settings where sexual reproductive health and rights challenges for women with disabilities are exacerbated. Yet it is simply forgotten. The recent COVID pandemic has increased these inequalities. The global report on COVID-19 and disability revealed a serious breakdown in the provision of support for people with disabilities who are without access to basic necessities such as food and nutrition, lacked information on how to keep themselves safe, were forced to battle against significant barriers to receiving health care, even for those living with long-term chronic conditions. However, even that report did not speak about the sexual and reproductive health and needs of young women with disabilities. It was forgotten. More recently, the intersection of gender and disability under the COVID pandemic has been highlighted by UNFPA, whose last week launch of gender and disability under the COVID pandemic highlighted the barriers to access sexual reproductive health services, goods, and the decreased ability to exercise bodily autonomy for women with disabilities during the pandemic. At the same time, exposure to gender-based violence has increased, we all know that, while support mechanisms and access to services further declined, in particular for women with disabilities. Taking a more local perspective, our Forgotten Agenda project takes the next steps and seeks to understand the impact of the coronavirus pandemic on the lives of young women with disabilities and their needs for and access to sexual reproductive health and right commodities and services in KwaZulu-Natal, South Africa. This project includes a longitudinal study with a cohort of young women with disabilities and those without, and strategic conversations with young women with disabilities themselves, researchers, government, and community representatives. Through these engagements, we will understand the experience of young women with disabilities better, but also be able to identify good practices and potential approaches to make services and interventions and emergency responses more inclusive. Having said all of that, I'm now handing you back to Samantha, who will take us through the first of these conversations and help us to make sure that we don't forget the sexual reproductive health and right needs of young women with disabilities in times of crisis. Thank you.
Thank you for that, Jill. Thank you for setting the scene and outlining the project we're working on. I'm now going to hand over to Thembi Zulu, who's going to speak about young women with disabilities and the SRHR crisis. Under the crisis of COVID. Thembi is the Deputy Director in Women and Reproductive Health in the National Department of Health in South Africa. She is responsible for program management, coordination of guideline development, and supporting provinces to develop and implement strategies. She coordinates contraceptive services, termination of pregnancy, sexual health, and the fertility program across South Africa. Thembi sits in an incredibly important position in the health system in South Africa, and we're incredibly honored to have you with us here today, Thembi, to share your experience, your knowledge, and your thoughts with us. Thank you, Thembi. If we can put up Thembi's slides, please.
Thank you very much, Jane, for this opportunity to share our thought as the department. So thank you for this opportunity. Thank you very much. I would like to have the next slide. Okay, my introduction to my slide is the person with a disability have a general poor health, lower education achievement, fewer economic opportunities, and higher rate of poverty than people without disability. This is largely due to the lack of services available to them, like information and communication technology, justice or transportation, and the many obstacles they face in their everyday lives. The obstacle can take a variety of forms, including those relating to the physical environment, or those resulting from the legislation or policy, or from the societal attitude and discrimination. And then due to multiple interesting forms of discrimination on the basis of gender and ability, women and girls with disability face a unique and pervasive barriers to full realization of their sexual and reproductive health and right. Attention to the SRH need of a person with disability is important to ensure the protection and promotion of their human rights, to move forward the international development agenda, and to build a truly inclusive society. Next slide. Next slide. And what are the sexual reproductive health needs and challenges of a young women with disability in South Africa? And then I'll start with the challenges to address what are those challenges that are face young women with disability. The first challenge is it's increased risk of poverty and dependency. Remember, most of the time they're excluded most of the things, so they are faced poverty and independency. Increased risk of HIV infection and gender-based violence. Women with disabilities are 2 times as likely to experience intimate partner violence than their peers, and are more likely to be infected with HIV. No data on unintended pregnancies. Lack of access to SRH services such as comprehensive sexual education, SRH clinical services, GBV prevention, and post-violence care. That are those challenges. The other challenges that they face negative perception of health and personal towards people with disabilities. And another thing that they face, disability unfriendly infrastructure and health facilities and COVID emergency responses. Also, they are faced with absence of trained personnel for people with disability, like, for example, sign language. If they go to institution or facilities, we find that no one understands them because no one are being trained on sign language. Healthcare providers generally demonstrate a lack of insensitivity, courtesy, and support for women and girls with disability due to lack of appropriate, due to lack of appropriate and evidence-based training for healthcare providers. Next slide. Next slide. Okay, as I was addressing the challenges that are faced by young women with disability, also we have come to an understanding that also there are some needs that we need to fulfill as the department. What they need full access to environment, which address their disability, like they need to be accessing in towns. They must be accessible. They must be a way for them to go to town. There must be a way for them to access any building. And then also there must be an access in terms of transport. If they want to move around anywhere, they need there must be an access to use the transport. And then also there must be a technical aid and equipment for them. Also, there must be an access and adapted to housing. And there must be an access in terms of personal assistance and support, as much as other women need support as well. Also, they need support. There must be an inclusive of education and access to comprehensive sexual education for them, and as well adequate income. So I just want to also emphasize to that also, as much as also everybody needs income, also they need income as well. They must be also must have equal opportunity for employment. And as much as anyone need to be employed, also they need to be employed as well. There must be an appropriate and accessible information for them. We normally say knowledge is power. So also if there's something new that need to be addressed, and also they need to be addressed, they need to have access of information. There must also advocacy for them towards the independent level. Also, they need counseling and support in their daily life. Or they must be appropriate and accessible healthcare. Thank you. Next slide. Okay, how did the department responded to SRH need of a women with disability before COVID epidemic, and where are the gaps? The Department of Health has recognized the need to develop the better SRH services for persons with disability through the following steps. In 2019, we developed the SRH policy and interrelated guideline. In those policy and guideline, we also included the information around a person with disability. And then from the 19 to 13 November 2020, the policy and the guideline were disseminated in all the provinces, so that the provinces must be able to implement such policies and a guideline. From the 14 to 19 March 2021, the department, in collaboration with other partners, we sort of orientated the provinces, all the provinces and the partner on the SRHR training package for healthcare workers so that they can further cascade information in their respective provinces. So in that module that we have developed, we also included the module that is talking to disability, which is module 11. And then in that training package that we have developed, it has 14 modules. And as I'm saying that also, because we wanted to include a person with disability, and then we included that module. The module is called Disability and SRH, which is module 11. So far, what we have done, and all the provinces have been orientated on the training package, which is the module, which is the curriculum that I'm talking about, SRHR, which include disability in SRH. And then provinces has been orientated in that module, all of them. The provinces are busy cascading as we speak, cascading the training in their respective provinces. And then the department needed to develop and monitor an evaluation tool to follow up the implementation and change over time. Next slide. How did the COVID epidemic impact young women with disability and their SRHR needs? COVID-19 has deepened the layer of vulnerability and changes for persons with disability and discontinuity in the health system. And then increased poverty, isolation, and lack of access to services has played a very bigger role. Some COVID regulation provided specific challenges to people with disability, e.g. how practice social distances when the need has for assistance. Increased isolation and then stress and families and lack of support led to increased abuse. Unable to access SRH services as these were often perceived and non-essential. Possible unplanned pregnancies as well as STI. What does the DOH need to respond to SRH need for women and disability? And then in terms, we wanted to ensure accessibility by making health services accessible and monitor this through annual disability audits. Information, we need also to give them more information. Good and service must be accessible to persons with disability. And then we need to be sensitive to their needs and provide that on their basis of the non-discrimination with the reasonable accommodation as needed. We need to guarantee all women and girls can access health and society and social services, accommodation, protection from violence, and just without fear, unrest, deported or discrimination by service providers. In terms of engage women with disabilities, we want to ensure women with disability are equally represented and can meaningful participation in decision-making, planning and implementation, monitoring and evaluation. In terms of consider diversity, we want to address the different needs of women and girls, paying attention to the most marginalized and diversity of the women with disability. And then in terms of providing disability training and sensitization, we want to train care workers to work with women and girls with disability and provide services that are based on dignity and respect the autonomy of the person with a disability. Furthermore, we want to train management and policy developers to develop a disability, a policy that includes person with disability. Also, all the regulation and program must include person with disability, just to avoid further discrimination. And in terms of develop disability, including emergency response, we want to ensure gender and disability inclusive response to emergencies such as COVID-19. We want also to include SRHR during and post-COVID-19 pandemic as essential service. Ensure long-term SRH for women and girls with disability in the recovery from COVID-19 and beyond. In terms of increased data and information on disability, we want to collect age, gender, and disability sensitive evidence to create more equitable solution to the disappropriate impact of COVID-19 responses on women and girls in their diversity and prompt share good practices. And let's learn in this regard. Longer term, and we want to ensure disaggregation of data is mainstreamed into outbreak and emergency response planning and preventive measures. And then in terms of support advocacy and awareness raising for disability, We just want to encourage decision makers to empower people with disability to be role model, make decision independently, and retain legal authority to make a decision. Also, we want to ensure partnership with organizations of persons with disability and support their advocacy work. Lastly, we want to support activities to raise awareness and address misconceptions, stigma, a lack of knowledge about disability, because we are aware that people, there are a lot of stigma attached to them, and also people, they don't have enough information. So also there are a lot of misconception around person with disability. So we want to create awareness around that, so that people or healthcare workers must understand the person with disability, that they are just like any other person. Also, their need is like any other person. Okay, thank you very much. I think that was my last slide. Thank you.
Thank you very much, Thembi. Thank you for providing us with a very comprehensive overview of both the policy and the actions from the department, a lot of detail, and I'm sure that there are a lot of questions that will come about that. And we'll hold any questions people might have until after we hear our next speaker. Thembi, thank you for giving us so much information, and for you and your department for taking this so seriously. We really appreciate it. Let me move on to our next speaker, who is Anya Smith. Anya, Thembi, would you mind turning off your camera? And we can, perhaps, Anya, you could turn on yours. Thank you. Anya Smith is a development economist working at Precept, which is a Cape Town-based consultancy. She's also a researcher at Research on Socioeconomic Policy at the Economics Department in Stellenbosch University. After spending 8 years of her career consulting in the areas of access to financial services and financial inclusion, she then pursued a PhD which looked at financing, delivery, and user acceptability of healthcare in South Africa, which is obviously incredibly relevant. And her other interests, which really speak to today, include maternal health, SRHR healthcare, and measurement of quality of healthcare. Anya, your presentation has been prepared with Professor Ronald Berger. We are very honored to have you presenting it today. Thank you very much.
Thank you. Thank you so much, Samantha. I'm just sharing the slideshow. Can everyone see that? I'm going to start from the beginning.
Start.
Oh, okay. Can everyone see the slides? I'm going to assume you can. Thank you. Thank you so much for this opportunity. I'm speaking from a very cold and dark and rainy Cape Town today. So it's glad to know there are people sitting in more, I think, sunny parts of the country and the world. And the work I'm presenting today is really about the example of access to quality contraception services within the larger space of sexual reproductive health services and rights in South Africa. And we are looking at it from both a sort of a quality perspective, but also resilience perspective and what happened during COVID. So we know that unplanned pregnancies are a SRHR challenge in South Africa. And that 2/3 of women aged 15 to 49 were actually reported having an unintended pregnancy in 2012, in the 5 years preceding when this particular survey was done. So we know from this survey, but also various other surveys and also qualitative studies, that unplanned pregnancies in South Africa, the level of unplanned pregnancies are very high. We also know that there is still quite low overall contraceptive use in South Africa. from the Demographic and Health Survey that was done in 2016, overall prevalence rate of 58% of modern contraceptive methods was found. And I think we think that this is quite low in a country where theoretically people have access to free contraception methods and services if that is what they required. From various sources, we know there's also low adherence and high failure rates of contraception, yet very little is still known about the quality and I think reliability and to some degree also resilience of contraception care in South Africa. And because of that, this is a stream of work and research we delved into. And today I'm summarizing findings from 2 recent studies. One which was done as part of my postdoctorate, where we looked at the quality of contraception care and advice given to women in South Africa, not only young women with disabilities, all women, and also then the post-COVID decline in access to contraception services in the public sector. So the information I'm sharing with you on quality of contraception advice and care comes from a study we did using a methodology called the standardized patient methodology, where essentially one uses most fake patients that are community members or actors that have been trained in presenting in a very standardized way at healthcare facilities. So they share a standardized sort of set of symptoms or questions that they're there to address. And because the information they present to the healthcare workers have been standardized, one can then expect to measure the responses that they are provided with by the healthcare workers. And this is a method used worldwide to obtain more granular and reliable information on patient experiences of primary healthcare services. And the idea around the methodology was, it built on examples that were used in the medical training of students. And we did this work in 2016 and did 152 analyzable visits across 2 provinces of South Africa in the metro areas. And what we found, I think, specifically on the diagnostics and essential questions side in contraception, is that I think the overall levels of essential questions asked and also information offered by the healthcare workers were very low. And it's very concerning to us that in the best performing province, in only 55% of visits were 3 or more contraception options explained. In the worst performing province, it was 19%. And then also, I think even in the best performing province, in less than 60% of visits were the advantages and disadvantages of different contraception options explained. And that was only about 33, almost 34% in the worst performing province. In general, women were typically given a choice, but often this was a choice between a very limited set of contraception options. In very few visits was the right, I think, information also requested from the patient visiting the facility. So you'll see, I'm not going to talk about all these questions, but in the best performing province, only in 50% of visits was the patient actually asked about her own medical history. And I think this is a really critical part of any contraception visit to understand the story and the medical history of the patient, because it offers certain contraindications that influence the choice of contraception. And I think very concerningly, in the best performing province, only about 35% of visits were questions asked about the life circumstances of the patient. That would also influence the type of contraception that's actually recommended and prescribed. Following this pattern, clients were actually offered very few contraception options to choose from. So in only about, if you look at the total, if you add up the numbers in brackets, in only about 30% of visits, well, not only, I should be saying in 30% of visits, patients were either not described any type of contraception by the healthcare worker, or only one type of contraception was described. And this is very worrying in a system where the recommendations actually say that there are up to 5 different types of contraception options available to women, and actually these options should all be explained. When we look at specifically the question of access to contraception and what has happened during the pandemic, we were able to access data from the district health information system, which was provided to us by the Department of Health as part of the larger NIDS-CRAM study. And because of this data, we were able to compare the trends in contraception provision, specifically in the couple year protection rate in April and May 2020 to what had actually happened in the 2 previous years. And if we just look at the raw data, so this is data where we're not controlling for any specific factors through statistical analysis, through regression analysis. But if we just look at the very raw data across South Africa, we see a very clear decrease in the couple year protection rate, which sort of started from February last year. It reached a low point in April during the very high and extreme lockdown level where we started, and then it slowly increased, but dips again later in July with quite poor recovery even in August. And these couple year protection rates were much lower than had been experienced in the previous year. When we do slightly more detailed analysis and actually look at what had happened with contraception levels, again using the sort of couple year protection rate and some other indicators to measure contraception coverage, we see that 75% of districts' contraception levels had actually not returned to their expected levels by August 2020. And this, I think this is very concerning, because we know it has access to contraception and unplanned pregnancies have very real long-term consequences for women and the households in which they reside. When we look at who was actually affected, we took this data from questions that were asked to women on the Mom Connect platform in May last year, we see that the poorest 20% of women in South Africa were actually worse affected by sort of demand side and behavioral, but also I think some supply side changes potentially in access to health facilities. And across all the questions that were asked about why did they not visit a primary healthcare facility during the stage 5 and stage 4 of lockdown, poorest women actually gave the highest responses, and you'll see that there was a big sort of fear of getting the coronavirus. Women also mentioned long waiting times, transport problems. So it was really the very vulnerable parts of society that were worse affected by access problems in contraception care. What can we conclude from all of this? I think we know that there were pre-COVID problems with the quality of contraception advice in South Africa. Firstly, there's not enough information about women actually seeking advice, and then also not enough information given to women when they do seek contraception care. And women are also not always allowed to make choices between all the options. And from the analysis using the district health and information system data, we saw that contraception access actually shows very low resilience when the system is in crisis. And we have certain questions as researchers about whether this is attributable to low prioritization of contraception care amongst users, and also potentially too few distribution channels. At the start of the pandemic, we saw photos in newspapers actually of condoms in certain supermarkets and stores having been cordoned off and people not being able to buy them, because in the early stages of the lockdown, these were viewed as non-essential products. So it seems that there was sort of a societal deprioritization of access to contraception services. And as I just showed, the most vulnerable were really the hardest hit and the most likely to avoid clinics, especially due to fears around the coronavirus and catching COVID. And that is it from my side.
Anya, thank you very much. Incredibly useful. Very, very depressing, but useful data to have. I mean, we need to have the full picture in order to be able to respond appropriately. And as we've all keep on saying, if this is the situation for most people, we can be assured that it's probably even worse for people living with disability, and that's what we need to figure out. Anya, there was a question for yourself, and it came up directly to us, which was you very clearly showed how contraceptive use declined during COVID, and worryingly how it hasn't returned to previous levels, and worryingly that's greatest amongst the poorest in the country. Do you have a sense at all around how this impacts on things such as other SRHR services? I know it wasn't the focus, for instance, HIV testing, ARV adherence, cancer screening, terminations, etc.
Thank you for the question, Samantha. So I think firstly, very similar trends were, I think, also seen around just access to those services sort of individually. But we also know that when women go for a contraception visit at a clinic, one of the questions that has to be asked to them according to the clinical protocols is whether they would like an HIV test. And I think some other screenings like potentially cervical cancer screenings are also often combined with contraception visits. So I think from the DHIS data, but also from various other data sources, we know that access to those types of care were also severely impacted. And I think during this current round of lockdown, where there will definitely be more supply side impacts, clinics shutting down, not enough staff available, but also people just having fears of the virus, contracting it at the clinic, and maybe not having the money to actually pay for taxi fare to go to a facility, there will again be very large impacts.
Thank you, Anya. Absolutely. Veronica, I think you're having a problem unmuting. Sorry about that. I'm going to put one of the questions. Veronica did send her questions through in advance. And two of them I'm going to put to the roundtable participants later. The one question, Thembi, which I think is very important, which came from Veronica, is a question about, you've talked to us, Thembi, about the amazing policies and programs within the Department of Health around SRHR. And Veronica Beloy was wondering, how can the government assist in improving transport facilitation for persons with disabilities? Because transport is a major problem, especially in rural areas. How can the government support to get people with disabilities to clinics for SRHR purposes? Thembi, can you comment on that very briefly, please?
I wouldn't come out with an answer now. However, I can take back the comment to the team, because also we've got the Department of Transport. Maybe we can have a discussion how best we can work this out as in collaboration with Department of Transport as Health to assist. Yeah, but it's not an answer that I can provide it now. We need to go back and sit and check how best we can work it out, including the Department of Transport. Thanks.
Thank you, Thembi. Fair enough. Veronica, from our side, I'm going to put ourselves on the spot and say that we will undertake to follow up with Thembi in a few weeks and see how that conversation has gone. And Veronica, we have your details and we can come back to you. I think this is a very important item and we undertake to make sure that it doesn't fall off the table. So thank you, Thembi. We'll carry on that conversation with you. I don't see any other hands, so I'm going to move us on. If you recall, we are now going to hear an amazing poem and then we're going to move into our roundtable conversation, and then there'll be more questions at the end. Veronica, would you like to type your question and we can come back to it afterwards?
She has typed a question in the chat box, Samantha. So she wanted to know from, and maybe that's the question, the last one you do before the video. She wanted to know, I think this is for Anya, or it is Sue Philpott as well as a guest. They want to know that the research focused on which level it focused, if it is facility level, because the clinical guidelines clearly state that women should be provided a choice between the 5 contraception types that should be discussed as an option. This often doesn't happen. They got that, and they would now like to know, women are typically only offered access to injectable contraceptive with limited discussion on other types and very little awareness that they have. So could you elaborate on what level, is it institutional level or is it family level where these conversations take place, the options on contraceptives, and maybe very briefly, and we can then collect more.
Yeah, so sorry, I'm supposed to respond. We just focused on what is supposed to happen at the facility level, because we have these amazing clinical guidelines in South Africa, very detailed. And our research question was about the quality of care as measured by healthcare workers following the clinical guidelines. And if you look at the clinical guidelines, they very clearly say women must be offered a clear choice between the different contraception options available in the public healthcare system in South Africa. And there's up to 5 different options available. And in many of the visits, there were no clear choice provided to women. And often there was only one type of contraception available, and that's really the injectable contraceptive. In nurses very frequently didn't discuss other options with women, didn't discuss long-acting reversible contraceptives, and I think this is very worrying because we know injectable contraceptives are prone to high failure rates when people don't go regularly for their next injection. I think there's also very little awareness on the part and empowerment on the part of women that they can actually say, but I have a choice and I want something different, or let's discuss other options. So we looked at it just at the facility level, but I think we are aware that even within the households, there's often very little discussion about the different options and also the options that actually work better for women. And we know that not only from South Africa, but also from many other low and middle income countries where in economics there are these amazing studies around finding that, you know, places like Zambia, women actually hide their pill packets in the maize meal because it is so difficult to discuss contraception in the home.
Thank you, Anya. Really appreciate that. Jacques, you've got your hand up. Would you like to come in with a quick question?
Yes, thank you. I see that I've been unmuted. So, yeah, I've got two questions or comments. First one to Anya. I just wanted to find out in the research what did they find was the impact of stigmatization with regards to young women not accessing services, because we found that because of a lack of awareness around disability and the stigmatization of young women with disabilities, that is one of the major reasons why sometimes they report to us in our projects that they do not access services. And then to Thembi, I just want to say I'm very excited about the points that you made with regards to what Department of Health needs to do with regards to the increase of data information on disability. I would like to know if you can maybe give us some pointers on how we would be able to approach that, and also with regards to the awareness raising of disability and the challenges that young people with disabilities are experiencing in the field. How will we go about to establish partnerships with organizations of persons with disabilities to enhance this collaboration? Thank you.
Thank you, Jacques. Before I hand over first to Thembi and then we'll come back to Anya, can I ask you to keep your answers very short? I'm sorry to do this, but we've got a lot to get through still. And this is the beginning of a 3-part webinar, so we will carry on asking these questions. Thembi, would you like to respond to Jacques? If you could unmute yourself. Thank you.
Oh, okay. Thank you very much. Regarding to the data that we said we are going to work on it, already we have started, as I was saying, that we have started developing the SRHR training framework. That SRHR training framework, it does have disability and SRH module. So in that we've included the data collection, M&E monitoring and evaluation in that. We are talking about as a learning session. Also, we have including the demand creation. How are we going to train the implementers on demand creation? Because we strongly feel that young women with disability, they need to have information around SRHR so that they must come. We believe that if they do have information around SRHR, they will be able to come and demand services in facilities, because if they don't have information, they will sit there and then not demanding the services that they need. So the demand creation is being covered in it's being covered firstly in module 1, because module 1 is a compulsory module, is a card crossing module. So it's covered in module 1, and then as well also it covered in module 11, disability and in SRH.
Thank you, Thembi. Thank you very much. Anya, would you like to come in quickly and respond, and then we'll move on? Thank you.
Yes, just very, very briefly. So I think we didn't, ours was mostly a quantitative study. We didn't focus a lot on measuring stigma from either a quantitative or a qualitative perspective. But we did hear stories from our field workers, the mystery patients or the standardized patients visiting the facilities, that especially the younger ones often did experience stigmatization, and I can only imagine it is so much more worse for disabled young women.
Thank you very much. I am going to move us on. Dr. Busisiwe Nkala, I see you have got a question. I wonder if you could type it into the box and we can come into the chat box, and we will pick it up at the end when we come back to Q&A at the end, if you don't mind, please. We will flag it to discuss at the end. Thank you. I'm now going to move us on, and I know we've been sitting in front of our computers for an hour, which says we all need a break. So for this next bit, you could actually stand up. And we're going to change gears quite significantly. I would recommend you all take a stretch. I'm going to in a minute. We're now going to move on to hear from a very passionate young woman who is blind. Her name is Anisi, and Anisi is part of the UNFPA regional initiative on SRHR and young people with disabilities. And she's an incredible advocate and supporter of the comprehensive sexuality education in and out of school. She has developed a poem, which we are going to share with you now. This poem was first heard last week, or at least I believe it was launched last week. I'm sure she had practiced it with other people. Last week during the launch of the UNFPA's Schools Comprehensive Sexuality Project. We wanted to share her voice and her story with you now. Jill, can you please call up the poem for us? Or press play, or whatever we have to do.
Yeah, can you see my screen?
We can see it.
Okay, I will press play.
My first periods, the worst nightmare. In the midnight of my 12 years birthday, I felt something strange. The vagina started bleeding. Don't be surprised. To me, it was a nightmare. Though I was not asleep, I thought that very soon I would wake up and that the blood should stop, but it didn't stop. I cried and cried, asking for help. Mom, please come and help. She quickly came to my room. When I showed her, she just laughed at me. Don't be afraid. You're grown up. This is what we call menstruation. As I have never been at school, as I have never got out of a house, even a single day, to have a chat with my peers, as my mother assumed that a blind girl like me didn't need that kind of knowledge, of course, I should not have had any idea about menstruation. In a blink of an eye, my mother brought me one of her oldest clothes. She cut it into big parts. My daughter, please use this so that you don't make your bed sheets dirty. Remember, I didn't have any skills about sexual reproductive health. I was not taught by anybody to do any kind of self-care. Guess the time my mother came to help to support me to change. 10 hours after. What a bad smell. What a lot of pain. How embarrassed I was. I will never and ever forget about that. Because this is the worst experience I've ever had. But finally, my life has changed. I escaped that terrible situation. Miraculously, I got the support and went to school. I got different skills. I know what menstrual hygiene is and its use. I can make my own money. I can have access to water, buy sanitary pads and soap. But don't assume that this experience only happened to me. Menstrual health for girls and women with disabilities, especially those who are poor and those with severe disabilities, it's a big challenge. We find girls and women with intellectual disability on the street. We even find them in menstrual period. They look weird and dirty, but who cares? We just laugh at them and move on. Those who think that they are merciful, they ask God to stop menstruation for all ladies with intellectual disability. But that's not a solution. They're also human beings. Instead of that, let's stand, join hands, put our voices together and advocate for the removal of all barriers which hinder girls and women with various disabilities to fully access information and products of their menstrual health.
Thank you. I hope you all stood up, stretched your legs while listening to Anisi's incredibly powerful story and her powerful call. We are now going to move to the roundtable discussion. The roundtable discussion we actually pre-recorded a few weeks ago, and we pre-recorded it for 3 reasons. First, because of the sensitive nature of the conversation, we wanted to offer participants, especially young women living with disabilities, we wanted to offer them the opportunity to stop and take a breath, ask us to pause if necessary. And we believe this is important when we're asking for testimonies. Secondly, we wanted to reduce the stress of technical hitches on the day with people sitting in front of their laptops. And finally, we pre-recorded to respect and comply with COVID care and good practice guidelines. So you'll see that unfortunately we're not sitting together on comfy armchairs chatting, which is what we would have loved to be doing. Instead, when we recorded, we were each sitting in front of a laptop in 4 different offices in our MRC offices. And then we had a producer put it together into one video. Let me briefly introduce the 3 people. We had a 4th person who wanted to share her story, but the more we talked about it, the more she realized she was not ready to share the trauma she had been through, which I think is an important reminder to all of us about what it means to testify. So we have 3 participants. The first is Inamandla Masinga, and they are the director and founder of an NGO called Pink Roses. Inamandla is an amazing person, and you'll see why during the conversation. They have a degree in environmental planning and development from the University of Zululand up Northern KwaZulu-Natal. They are living with albinism, and while at the University of Zululand, they began to realize how severely people with albinism are discriminated against. And Inamandla started a campaign to address this. And this is what led to her forming the organization. Inamandla then began to realize that she wanted to do more than just advocate for the rights of people living with albinism, and extended her advocacy and her NGO's focus to all young people living with disabilities and access to SRHR. She formed Pink Roses in 2019. Inamandla works locally and internationally and has already started working with organizations like UNFPA. Inamandla is an amazing person and advocate. The second person you'll hear from in our discussion is Dudu Radebe, who's the managing director of an NGO called Create. Dudu is a social gender activist, as you'll hear as she testifies. She's worked with NGOs her whole professional life, international, local, CBOs. Her passion is to promote the inclusion of people living with disabilities. She became the managing director of Create, the NGO based in Pietermaritzburg in Northern KwaZulu-Natal, in March 2020, which could not have been an easy time to start a new management role. In this role, she supports critically important work of CREATE, which includes educating people about disabilities, community-based rehabilitation, especially in rural areas where a lot of their work is done, addressing stigma against people living with disabilities, and supporting the realization of people with disabilities rights, SRHR rights, and more. The third and final person you'll hear from in the roundtable is Sister Mbali Struman. She's from the Department of Health Clinic. She's the operations manager at the Department of Health Mobile Clinic in Howick, which is near to Pietermaritzburg, northern KwaZulu-Natal. Mbali has been a nurse and now the operations manager her whole life. When I was chatting to her last month, I asked her why she chose nursing, and she simply replied, because I care about people and I can tolerate a lot. And I found that very moving. That really, I think, is the essence of what we need in our healers and our healthcare workers. Mbali was working in Balgowan, which is quite a rural area, at the start of COVID as a nurse, and then moved to Howick last November, where she became the operations manager. So her experience spans both as the nurse in the rural area and the operations manager at a mobile clinic. She also works very closely with Kulisani, who you'll hear referenced, which is an NGO in Pietermaritzburg, working on disability rights and access. So those are our three participants. We'll start playing the video now, please. It is about a half-hour discussion. Thank you.
You should.
Indamandla, I wonder if I could start with you. As a young person with a disability and an activist for the sexual reproductive health and rights of young people living with disabilities, what do you think are the greatest issues that are currently facing people living with disabilities in South Africa?
Okay, thank you. So I usually look at, when it comes to sexual reproductive health and rights services for young people with disabilities, I usually look at three things. It's access to information, it's infrastructure, and it is the stigma around young people with disabilities. So with access to information, it's really hard for young people with disabilities to access information on sexual reproductive health rights and services. Firstly, because most of them are not in mainstream schools where there's a huge focus on comprehensive sexuality education, and there are classes like LO. The other thing is some of them are in the rural areas where they don't even have access to an actual school. They don't even have access to an actual school where they will get like that little information during LO period and stuff like that. And there are very few organizations that deal with sexual reproductive health rights and services that is inclusive to young people with disabilities or specific to young people with disabilities. The infrastructure that is provided or that already exists in clinics is not always adaptable or accessible for young people with disabilities, be it not having a proper ramp for someone who's in a wheelchair, not having spaces that are accessible for someone who is visually impaired or blind, not having healthcare providers who are trained in sign language to actually be able to help assist someone who is hard of hearing or hearing impaired, which makes it very hard for a person with a hearing or visual impairment to actually work with or actually want to go to a clinic. Because if you don't speak my language or you don't understand me when I'm speaking, then how are you to give me the proper information or actually the accurate information that I need in terms of what I need? And then lastly, it is the stigma around disability and being a sexual being. Most people expect young people with disabilities or people with disabilities in general to be asexual, which raises a lot of eyebrows when a person with a disability goes to a health facility to ask for sexual reproductive health services. Most of our healthcare providers are people who are much older than us. Okay, I'll speak for me generally. I'm a 25-year-old young woman. Most of the time when I go to sexual reproductive health clinics, I find like maybe a 45-year-old woman, 50-year-old woman sometimes. And they have that traditional mentality, especially in, like you said, I went to UniZulu. They have that really traditional mentality of, what? You're an albino. Why are you engaging in sex? I thought people with albinism did not engage in sex and all of those things. And it's even worse for someone who's in a wheelchair to actually be comfortable enough to get those services or to actually go to get those services. Because you probably, here's an example. I had a friend back in varsity who had a physical disability and was in a wheelchair. We went to get sexual reproductive health services at the campus clinic. And the nurses, they were like, but like, you're in a wheelchair. Why do you even need this? Why? Like, it doesn't add up and stuff like that. And the first time we went, because of that treatment and that stigma from the nurses and all of that, she was discouraged to actually go back the second time and continue getting sexual reproductive health services from the clinic, because she was now like, every time I'm there, I'm going to have to explain myself as to why I'm here, why is someone like me here, and stuff like that. So those are some of the challenges. The challenges are access to information, be it the fact that you know something about sexual reproductive health rights, you have access to a facility that's going to teach you about sexual reproductive health. It's infrastructure, having booklets that are written in Braille, having a person who is trained in sign language be at a sexual reproductive health facility. And also it's the stigma around disability and sexuality. Thank you.
Thank you, Inamandla. Thank you for that. Very powerful. And I think an important reality check of what it means to be a young person with disabilities. Dudu, I wonder if we could then move to you to comment on that. As a service provider, Create is an NGO, you're the managing director of an NGO serving people with disabilities. Could you perhaps talk to us for a bit about how the COVID epidemic had impacted young people with disabilities' access to services?
Thank you, Samantha. So I think a lot of the things that Inamandla spoke about quite resonate with the experiences that we also encountered in working with young women with disabilities, because we did find that access was a big issue to information. Their ability to also access services, especially sexual and reproductive health services, was quite a big issue, in the sense that they found themselves also isolated as young women and not being able to go to clinics, either to get their contraception, to get information around reproductive health services that they could be able to access, but also just communication as well in terms of healthcare workers being able to understand their needs as young people with disabilities, being seen as people who actually would use that information, that information would be relevant to them. It was a big issue as well. And also just the issue regarding, the isolation that happens when you are in lockdown and not being able then to get assistance, especially social assistance, that's going to enable you to, when you are encountering an issue and you're needing someone to speak to and someone to advise you, someone to support you if you're experiencing sexual abuse as well, because there was also a lot of that was reported to us, where young women were locked in their homes with abusers or abusive family members, or family members who did not understand them or did not understand their disability. And so they did not have access to anyone who could actually be able to speak to them or able to support them. When they were abused, they were not able to even access support from the police and so on, because they couldn't report cases of abuse and so on. So all of those issues actually impacted young women with disabilities and made it more difficult for them to actually be human and be able to exercise their rights as well. So those are some of the issues that we encountered, and this also included situations where there was abuse and young women found themselves impregnated. And so again, there was an issue there because unwanted pregnancies became an issue and were reported to us. And so, you know, when that happens, there was no support as well for young women with disabilities as well.
Thank you, Dudu. And I think a lot of what you've addressed speaks to challenges generally faced by people with disabilities and how exacerbated it was. I mean, in level 5 lockdown, you could not leave home. By level 4 lockdown, to leave home, you had to have what was considered a very, very important reason. And for many people with disabilities, that was not an option for them to leave. Sister Mbali, I wonder if I could turn to you, because I think that builds on what Dudu was talking about very nicely. As the operational manager and a healthcare provider in the mobile clinic in Harwick, could you tell us a bit about the challenges that was faced by the Department of Health in supporting people with disabilities and supporting them to access sexual reproductive health and rights, particularly during the hard lockdown of level 4 and 5, but generally during COVID? Please, Sister Mbali.
Yes, thank you, Samantha. I think I have 2 experiences here, because at first I was working at the fixed clinic where we didn't have that much abilities. But in our facilities, we have outreach teams. So those outreach teams are the ones who support the facilities by going out to the community. During the COVID level 4 and 5, where people were not allowed to move out unnecessarily, the outreach team will go to the community and provide the services with the help of our community health workers. There was a group that was formed where the community health workers will speak to the outreach leader. Then the outreach leader will provide the services, because they do have e-transport. And at Kulisani, unfortunately, the school closed down during the level 4 and 5. So when the schools are closed, there's nothing really we can do, because we have the hope that the kids will go to the nearest clinics. Unfortunately, we didn't even have a chance to say the kids, or to speak to the kids about how are they going to do during the lockdown. And that was a big challenge, because others, they came back after 2 months. They didn't go to the nearby facilities for their reproductive health services, and others, they come back pregnant. And that was a big challenge, especially for us, because we don't really understand these kids, and there wasn't much that we said to them about visiting other facilities for their health, reproductive health services.
Thank you, Sister Mbali. And I think that's very important, the distinction between what happened during the hard lockdown, where schools were closed and people returned to often rural family communities, whereas how we're living now under the lesser lockdown, people have access, and it seems that a lot has gone back to how it was in terms of accessing SRHR. But what happened during hard lockdown, unfortunately, seemed to result in a lot of unintended pregnancies and women not being able to access reproductive care. And it makes me think back to Inamanda's point around The fact that if you are a person with a disability, you may have found a clinic where you're comfortable going and a healthcare worker who is supportive. But if you now have to go back to your family home, you may not feel comfortable in that clinic because of your previous experiences. So I think what I'd like to do now is try and move forward into a little bit of problem solving and what could we do better. What have we been able to do successfully? And if we could do it all again, how would we do things better? So Dudu, I'd like to start with yourself and your NGO Create. And I know that during the lockdown, you were doing some very important and powerful work with many people with disabilities. Could you tell us a bit about what Create was able to do, both so that we know, but also try and draw out lessons for us so we can be better prepared in the future? Thank you.
Thanks, Samantha. So the work that we did was in collaboration with other organizations that were also concerned about just the situation of marginalized people in general. And so we brought in the aspect of people with disabilities into that work. And this included, it started with looking at the needs for food, because as people were locked down, they were not able to travel to buy, and also a lot of people didn't have the resources that they would have needed actually, or they would be able to get by working. So people had a lot of issues relating to just not being able to have enough food to eat. And because of the way that we did the delivery of food, where we went into people's houses, and we also got to understand some of the challenges that went beyond the food, we quickly realized the need, especially for people with disabilities, and in that we including young women with disabilities, the need for special things that are relevant to people with disabilities, such as diapers, adult diapers, things such as bed covers, things such as sanitary pads, soap, and so on. And so we had to think about all of those things. So our packs or the food that we provided included that, and we're also supported by a number of other organizations. So we ended up adding things such as Wonder Bags, where we had to think about, again, energy. And so our packs also included things like the Wonder Bag. We included things such as vegetables, because also we understood that from a health perspective, they needed, to have healthy food. And so we collaborated with organizations that work with subsistence farmers. And so we got a lot of vegetables such as sweet potatoes, spinach, and so on. And so that helped us to provide a package of support, or a care pack that went beyond food, and it included things that were relevant to people with disabilities, and also to young people, young women with disabilities, because, when you look at things such as sanitary pads are quite important for them, and realizing as well that they were so dependent on the disability grant. But the disability grant, because there were so many people in the family that were back at home, the disability grant ended up being used by the whole family. And so there were additional needs that were specific to young people with disabilities. And so we had to think about those things. So we were quite blessed to get support that went even beyond local communities, where there were donations that were coming through, and also international organizations that supported us to do all of this work, including actually from a psychosocial support perspective, just going into the household. Because of the isolation, it was quite great to actually have people who could come and talk to you and actually find out if you're okay. If there's a case of abuse, you can be able to tell them that I need this help because this is happening with me. And we also developed a system, for instance, where young people who are abused, especially sexually abused, to have a way to communicate. If, for instance, I'm locked in the house with my abuser, if I hang something that has a red color on the line, people will know that something is wrong in their house, and they should then come in and try and find me and try to help me. So we had to develop a language that would be possible for young women with disabilities to actually be able to communicate without alerting the abuser that they are locked up with, that something is wrong. I need someone to come in and help me, someone to come in and rescue me, take me away, something like that.
Thank you, Dudu. That is so powerful. And I think it speaks to something we were talking about earlier on over coffee this morning, where we were talking about how sometimes people with disabilities have a carer who's responsible for them. And sometimes that carer is actually not caring for them, but is the abuser. So those systems you're referring to are so incredibly important. Thank you, Dudu. I wonder if you could just in 10 seconds, was there any kind of WhatsApp line or SMS line or anything that people were able to use to report abuse or get information? If you can just in 10 seconds touch on that.
Yeah, so we did set up and it's an ongoing service that we have set up where people can report abuse through a WhatsApp line that comes directly to us.
Thank you, that's wonderful. And it's ongoing, which is brilliant. Thank you. Sister Mbali, if I can turn to you. Looking forward, if I had a magic wand and we could turn back time, and it was before COVID, and we knew that COVID was coming, and we knew that we were going to enter into hard lockdown, and we had some time to prepare. What do you think we could have done better? What could healthcare workers in the Department of Health, what support could we have given them? What training could we have given them so that they could respond to the needs of people with disabilities more effectively?
Thank you, Samantha. I think firstly, because I think the healthcare workers don't understand disability, and including me. And as we were talking before we had this session, I was listening to Inamandla talking about albinism being an disabled. And I wasn't aware also that if you are an albino, you are disabled, you have a disability. So I think these are the things that people need to know, especially the healthcare workers. I think we need trainings. After trainings, we just need people who will give us in-service education and keep on updating us about the information so that we'll be at the same level with all other people who are dealing with the people with disabilities, so that we'll be all talking the same language and doing the same thing for all our communities. And also, I think the youth-friendly services will also help, because as we are saying, people with albinism are having a disability. Maybe once, if they come together with other kids and they just do other things, they know that there is someone to talk to, especially because at the youth-friendly services, there is a champion, a nurse who is at the same age with the kids. Then the kids will be able to ventilate and talk to her, and also to have things that will make them happy at home, because it's not that they are only having sexual reproductive health problems only. They are also having problems at home, like Dutuzile spoke about sexual abuse and all those things. They will know, because the champion will also know how to deal with these kids. And also us as healthcare workers will also know what to do.
Thank you, Sister Mbali. And I think that's a very powerful call, that for recognizing that for many, many healthcare workers, there's just not an understanding of what it means to have a disability. and then how to support people with disabilities. So that training is so incredibly important. And of course, that's what Inamandla and Dudu's NGOs do all the time. So hopefully we can all come together and address this. I'm going to put my last question to Inamandla. And as I said, we're looking forward now. We're problem solving. Inamandla, if you were asked to advise the President of South Africa, you were invited to advise Cyril Ramaphosa and the Minister of Health this afternoon, what would you say to them? What would you like to see for young people with disabilities that would enable them to access SRHR services and rights?
I think that's a good question. One of the things that we were able to do last year in the Pink Roses Foundation was we did it with Dr. Jill actually, a review of the current National Strategic Plan on HIV and stuff, the SANIC NSP. They are currently in the midst of making another one for the 2022, I think, to 2027 year plan.
Yeah.
So one of the major things that I noticed was, and the entire plan, and it's a big plan. In the entire plan, the word disability or disabilities is mentioned at most 10 times. And even when it's mentioned, it's only mentioned for people who have who acquire disabilities like after living without a disability. So let's say you got your disability because of HIV, you got your disability because of you got into an accident, and then now how do we help you not get HIV, or how do we do that? Nothing is mentioned for people who were born with disabilities. There is no mention of how to cater for the needs of people who are born with disabilities. Mm-hmm. So for me, if I were to advise the president, because he's the co-chair of the SANIC Civic Society, the first thing would be, let's look at the policies that you're making. Start by considering people with disabilities from birth, the same way that we consider kids that are born with HIV, like just everybody, like start considering people with disabilities and their needs from birth. Look at us as people who are sexual beings, because we are sexual beings. So when we make campaigns or we make policies that are for the general public, just have something that talks on disability and stuff like that. For instance, the NSP also tackles the LGBT plus community. People with disabilities are also part of the LGBT community. I am part of the LGBT community. So, but then in LGBT spaces, there's very few spaces where a person with a disability can exist freely. So it's by creating spaces for people with disabilities to be seen, like raising visibility, first of all. And also, I think Sister Mbali also touched on this. It's facilitating and sensitizing healthcare workers on disability and people with disabilities and their specific needs. Also, it would be really helpful if we started, like every day when I go to a clinic, I get a pamphlet on how to prevent myself from getting HIV, what PrEP is, and all the other SRHR services. I've never in my life seen one that was written in Braille. Maybe I have not looked enough, but if stuff like that was more accessible, having a healthcare worker who is trained in sign language should also be a thing. Like, why don't we have healthcare providers or sign language interpreters at clinics? Why don't we have that? That should be, because like sign language is like the 12th language in our clinics. We have clinics that I can go there and freely speak Zulu, but then why can't I go there and have a sign language interpreter help me? Why isn't there any information written in braille and all the stuff like that? So it's increased the amount of access to information, not just by just giving it out there, but also increasing the ways in which that information is sent out to the world. Increase, have at least one in each facility, so one sign language interpreter. Have someone who's going to translate everything that we already, all the information that we already have, translated into braille. There's a lot of people who are going to get help about with that, regarding that, and change the policy. 2022 is coming up. The NSP is going to be changing. I would like to see disability mentioned more than just 10 times. I would like to see disability mentioned more than just a thing that happens after you've been alive. What about us who were born with it? And just also make it inclusive to all 18 civic society societies. Make it inclusive. I want to get into spaces where the traditional sector is speaking on disability, because also as a person with disability, I face problems of stigma amongst the traditional sector, where people are killing people with disabilities for methodological reasons. I want to be a person with albinism and find my seat in the LGBT space. I want to find my seat as a young woman with disability. I want to be in the women's sector and feel represented, not just by myself, but have other young people with disabilities included in all of these spaces. I think that's all I can say.
Thank you, Inamandla. Thank you. That was incredibly powerful. And let's hope we can get it to the president to listen to. That would be amazing. That was a very powerful plea, and thank you for that. Unfortunately, we're going to have to wrap this up now. I've really been enjoying this conversation. I think we could carry on for a long time, and we can over lunch, but unfortunately, the viewers can't. I'm going to ask you each to take 30 seconds to make your last statement, your final comment. What is that one thought that you want to leave with everybody who is participating today and watching us today? In 30 seconds, what do you want people to remember? Dudu, can I start with you?
Thanks, Samantha. I think I'll talk about two things that are quite important for me. The first one is that young people, especially women with disabilities, need to have spaces where they can engage with each other. So support groups for their caregivers, so that they can also know how to support young women with disabilities. And the last one is also to increase access to education, because that enables young women to be independent and also ensures that they have agency, they have voice. Thank you.
Thank you, Dudu. Very powerful. Sister Mbali, can I turn to you for your final remarks, please?
Yes, thank you, Samantha. I think the best thing that I can offer is that they must know that living with a disability is not a sin, and we should all people treat each other the same way as we all want to be treated, especially when they come to the health services. I think we have to treat them nicely, because they are also human beings. And also that, as she has said, Tutuzile, they must have these support groups. As I've said, that we also have to strengthen our youth-friendly services with the youth who have disabilities also, so that they will know that living is good, and they can live with other people, and they do other things that are done by other people. Thank you.
Thank you, Sister Mbali. And Inamandla?
Thank you. I think my strongest point would be that young people with disabilities are not asexual. And because of that, they are entitled to all sexual reproductive health rights and services as the general public. we need to strengthen the service providers' capacity to actually work with young people with disabilities. And we also need to integrate civic society organizations to be able to work with young people with disabilities, to be more inclusive of young people with disabilities, and create more disability inclusive spaces rather than creating isolated disability spaces. So within every space that young people are there, young people with disabilities have more than enough capacity and access to be in that space. So create access for young people with disabilities to always be there in spaces where young people are concerned, and just let's live.
Thank you. What a wonderful way to end. Let's all just live. Thank you. We've heard a lot today. Incredibly powerful. Thank you to all of you. And I think just in concluding, I just want to say that what I think has been raised is that we're all aware that accessing sexual reproductive health and rights is difficult for many, many young people. Whether it's getting contraceptives, whether it's being able to use the condom at the moment of sex, whether it's experiencing intimate partner violence or stranger rape, it's difficult for most people, young people. We also know that living with a disability is incredibly difficult for many young people because they're marginalized, because they're not included in so many spaces, as Inamandla was talking. Then we also know that COVID has been incredibly hard. And I think it's been incredibly hard for every single person here today, watching today. And so what we've just talked about is the incredible difficulty of when those three come together. A young person trying to access their sexual reproductive health and rights, who also has a disability and living in a time of a global pandemic. It's an incredibly difficult time. But what I love is that you all came with solutions, and you all showed us how it can be different and the amazing stuff that has already been done during COVID, and what we would like to see people like our Minister of Health and President doing differently. So I just want to conclude by saying, I think all the difficulties we've had must change. And I think we should all commit ourselves, everybody watching this webinar today, to commit ourselves to ask questions. Every time we're starting a project or research or talking to a young person or being a healthcare worker, have we thought about people with disabilities? Have we adjusted our campaigns and our facilities and our messages? Have we developed Braille pamphlets? Have we got sign language interpreters in every single region? Have we supported young people with disabilities to be able to advocate for themselves with funding, to be in all the meetings? How different would our world look like today if we were all able to really listen to these messages we've been hearing from everybody today? So, Durizele, Inamandla, Sister Mbali, thank you so very, very much. Your time today, your words today have been incredibly powerful, and I'm sure many people appreciate them. Thank you.
Right, thank you. We hope that the roundtable discussions generated more thoughts, that you could relate to them or were inspired by them, and we hope that everybody heard and learned something they hadn't heard or knew before. We have had some questions coming up as we were showing the roundtable, and there were one or two before, and I have undertaken, I think I've noted all the questions that are there. Before I move on to those, thank you again to Inamandla, Dudu, and Sister Mbali for participating in that and for availing themselves today. Unfortunately, Dudu had a pre-existing commitment. She can't join us. Sister Mbali is with us here in our boardroom, ready to answer any questions people may have. Inamandla was joining us, and then unfortunately she had a test scheduled for this morning, which really interrupted our plans. But let me move us very quickly. We have like 6 minutes to take a few questions and get some very succinct answers. First of all, Bradley, I wonder if you could put up the slide. Dudu mentioned that Create set up a number during lockdown that people could contact. And they also had a secret system where women would put up, I think it was a red cloth, to indicate that she needed help. help. That number is still ongoing. So you can either Google CREATE, which is an NGO in Pietermaritzburg, and get their details, or we will put a slide up shortly with their phone numbers as well. There was also a comment by Maria, who was urging us to remember that when we talk about contraceptives, so we need to also promote the female and male condom, because the female-male condom is obviously incredibly important for STIs and HIV prevention, as well as pregnancy. I am going to move on to a few questions. There are 2 or 3 which are related, and mainly for Thembi and Sister Mbali. And I wonder if you could answer them quite briefly. We may have to have another follow-up conversation on this. First, we had Busisiwe and Carla Klamini, who raised her hand earlier, and she was asking, often when clients come into the clinics, they actually have the information and they actually know their rights, but the service providers themselves have the power. And I think Ina Mandla was already speaking to this, where it's often the service provider, the healthcare worker, who actually judges, won't give the contraceptives, etc. And she was commending Thembi and the DOH, or the DOH, for the great plans, but saying realistically, how are we going to do this? Realistically, how are we going to address the attitudes and the stigma among some of our healthcare workers, which makes it so incredibly hard for young people to go and access contraceptives? And that also links into a question from Veronica, who sent it in advance and has placed it in the chat, where she's also asking, how can the healthcare workers, the Department of Health and partners, NGOs, support creating more of an awareness across the public services, the clinics, the hospitals, and other services, so that patient care services towards people with disabilities actually comply with the Batapile promise of access for everybody? So those 2 questions really are about how do we make it real on the ground. We have Batapile, we have these amazing commitments from Department of Health, but we have healthcare workers who still stigmatize us. And then another question for Thembi, please, from Nicola, which is, please could you tell us very briefly a bit more about the annual disability audits? Have they started? Which facilities have they been rolled out to, and what sort of issues do they cover? I wonder if the disability audit is still just a suggestion, right? So what will they cover and where will they begin? I wonder if we could take those questions, and then I have a few more, but perhaps we could start, Thembi, if you could briefly speak to it, and then I'll ask Mbali to speak to them. Thembi, if you could unmute, please.
Okay. Thank you very much for the question. I'll start with providers having attitude towards young people. Yes, we agree. And we've noticed that what we have already done as the National Department of Health, as we develop this SRHR training package that include disability and SRH, and then we've been training them, what we have discovered that maybe the reason why sometimes they've been so difficult because they didn't have enough information around disability, because in our training that we've been conducting, and then it was clear that they didn't have enough information. And then as we're giving them more information around the subject matter, they realize that, oh, we've been doing a wrong thing. You know, we've been not having such information. We thought that we do have information. I thought as well, sometimes under normal circumstances, if a person feel uncomfortable about the subject matter, he created that wall so that no one must penetrate. You know, sometimes it's normal to create a wall so that a person must not understand that how far you can go around the subject. I think that has been an issue, but as I'm saying that we are busy cascading training, because for sometimes we never had the manual or curriculum that is directly talking to, or the module that is directly talking to a person with this disability in SRH. That's the new end. I think we are getting there. And furthermore, in SRH as well, we have introduced friendly youth services. And also we've got a module that is talking to youth-friendly services that also addressing young people with a disability. So we are getting there. We hope that we are going to achieve our ultimate goal. And then around the audit, that was my suggestion, or that we are planning to do. We want to do the audit. It's not yet done as yet. That's the thing that I think training is very important. Giving people information is very important. And that is why in my recommendation is my slide, I said the things that need to be done. We are going to mentor those people just to check whether whatever that we have given information to, they are adhering to it.
Thank you. So I'm hearing three things. I'm hearing more information, awareness raising, but I'm hearing training to make that real. And I'm hearing ongoing advocacy from people outside Department of Health as well for accountability and fast movement. Thank you. Sister Mbali, do you want to come in and respond to those points? If we can unmute the boardroom, please.
Okay, thank you, Samantha. About the first question of staff attitude, I think there's something that was done because we have the complaint suggestion box that is used by the clients. So I think the clients must get used to it and write their complaints because they are attended to, and not by the staff as such, but we are also involving the clinic committee so that it mustn't be biased. We'll know and how to make how to resolve the problem at the end of the day. And also we also do the surveys that are done. These surveys, they also even appear in our audit tool as a ideal clinic tool. So those audits, they include staff attitude, security in the facility, many things that are included, waiting times, so that we will see how we're doing. So it is also monitored every 3 months. So I think even to conduct our staff meetings, we are also doing those things, because if we conduct our staff meetings, we also know how people are feeling, and we must also know how people maybe need other things to be done, so that now they will work freely and be able to communicate nicely with the patients.
Thank you.
Also, yes, thank you.
Thank you very much, Sister Mbali. I think that's very, very important. And I think it also speaks to the healthcare workers also being under stress and also needing support and create. Sorry, I was muted. The importance of remembering that our healthcare workers also need support and debriefing. I'm very aware that we've got 2 minutes over. We have one last question that I would just like Jill to very quickly answer. And we will put up the slide with the number for CREATE. Jill, there was a question from Joyce where she said, mental health seems to be emerging more and more during these conversations over the last 2 hours. And is mental health of young people living with disabilities being considered in the program we're working on?
Yes. Okay. While I'm answering that, you should be able to see the CREATE contact details there. Is that correct?
We can, yes, thank you.
Okay, because I was supposed to share them. Okay. Yes, in the Forgotten Agenda project, we do consider mental health. In actual fact, that is one of the areas we prompt. So we're looking not just at what sexual reproductive health and rights young women can access. We're also looking at the experience overall during COVID-19, as well as how that affected their mental health. Yes, we do, and we agree.
Thank you. Thank you. There is another question in here for DOH. So I wonder, Tembi and Mbali, if you could just take note. We won't discuss it now, but DOH could consider registering with money for jam. That sounds nice. I want money for jam. And get end users to do the facility audits and earn money by doing the audits. So I think that means getting your patients to actually assess you, which is actually a very good way of monitoring delivery. There was also one final thing which has come through from one of our participants, Veronica again, which was a call that I think I'm just going to put out there. I don't think we have time to discuss it, but a call that we need an increase in the disability grant. For those of you not in South Africa, we do have a disability grant. It is very low, and that amount needs to be increased because we know that is insufficient for people living with disabilities. I am now going to I'm going to pull the session together. I'm going to start doing that by asking Jill in less than a minute to just tell us what's up next for the project, please.
Okay, great. Well, first of all, we will complete this recording and add it to our website. So you will find that on the South African Medical Research Council under the Gender and Health Research Unit. There is a project are listed there, and our ones is listed under Sexual Reproductive Health and Rights. Or you Google Forgotten Agenda and SRMRC, you will also find that very quickly. In terms of what happens afterwards, at the moment we are busy with a period where we researchers collecting a lot of data, which we then also will have to analyze. So you will have to give us some time. In the meantime, we're preparing with our advisory committee, but I've also taken note of a few other advocacy people here in that session, which we probably should start including in the conversation. We will prepare for World Disability Day, and around that day we will have another webinar and hopefully climb up and include other stakeholders that are important for this discussion. And yeah, we will obviously eventually have results, and those ones we hope to share in March next year. And then afterwards, you can expect some publications. Okay, thanks, Samantha.
Thank you, Jill. So it remains for me to thank everybody. Can I start off by thanking every single person who joined us today to be a part of this conversation. And some of you we've already worked with, some I'm hoping are new partners in this journey. I'd also like to thank our participants. Please also note Bradley has just put the link into the chat box. That is the link where you'll be able to find this recording shortly. Thank you, Bradley. So thank you to our participants. Thank you to Sister Mbali, Inamandla and Dudu, who came through a few weeks ago to record the roundtable and who tried to join us again today. And thank you, Sister Mbali, for joining us. Thank you to Tembi and Anya for two very powerful presentations and engaging in the conversation. Thank you so much to our sign language interpreters, to Shulamite, to Caitlin, to Buluwa. And I think many of you may not have noticed that there was a little glitch halfway through when Buluwa's had a power outage. And my huge thank you to the sign language organizers who very quietly in the background quickly pulled in Caitlin at last minute, and it seamlessly carried on. I'm very impressed, and there've been a couple of comments in the meeting chat thanking everybody, thanking the sign language interpreters. Really appreciate your work today. To the team that made this happen, thank you so much to Bradley, Ayanda, Lindo Muso, Nomfundo, the people behind the scenes who make it all happen, to Jill, to the IT people, Nelisiwe, Andrew, Patrick, Masulu, JP, all the people who move the mountains within the MRC. To all of our partners who we've been working with to get to this point, thank you so much. And finally, to our funders, who of course are quite important to make this happen. And we're very fortunate because we're supported by what's now called the UK Foreign Commonwealth and Development Office, FCDO. And they've funded the COVID Collaborative, which is based in the UK at IDS. And the collective brings together a number of UK and Southern-based research partners, social science researchers, to inform decision-making on COVID-related development challenges. And they've been amazingly supportive. So thank you to everybody. I think it remains for me to say everybody today has called for us to take policies that exist and make them real, take audits out there and make them meaningful, and essentially for us to all work and live differently, to do our research, to do our programs, to do our healthcare work differently, and always remember the rights and needs of people living with disabilities, particularly young women and their SRHR. Thank you, everybody. And we'll see you on the 3rd of December for the next webinar.
Thank you.
Thank you, everybody. Go well.
Thank you.